This is a cross-sectional rendering of the pharynx. By isolating the superior pharyngeal space on the left and the prevertebral space on the right, we can track exactly how fluid accumulations physically dictate airflow compromise. A peritonsillar abscess, or PTA, localizes strictly to the superior pole of the tonsil. Text outlines the physical signs of spatial compromise. Localized swelling forces the uvula to deviate contralaterally. The patient presents with a muffled hot potato voice and severe trismus, an inability to open the mouth, as fluid physically restricts the masticator muscles. Now look at the right side of the diagram, detailing a retropharyngeal abscess. Here, the infection localizes deep within the prevertebral space, situated between the posterior pharyngeal wall and the cervicostine. Because the abscess physically rubs against the spine, any neck flexion causes severe pain. Patients will instinctively sit supine with their neck extended to maximize airway diameter and minimize mechanical friction. The prevertebral space acts as a vertical conduit. Gravity pulls the accumulating purulent fluid downward, directly past the cervical fascial planes. If left undrained, the fluid breaches the mediastinal border, triggering acute, lethal descending mediastinitis. A peritonsillar abscess threatens the patient by mechanically occluding the upper airway, requiring immediate needle aspiration to decompress the local space. A retropharyngeal abscess threatens the patient through unchecked fluid descent into the chest cavity. In deep neck space infections, the anatomical coordinate of the fluid buildup determines the mechanism of death. The location dictates whether the patient asphyxiates from a localized mechanical block or crashes from a systemic descending sepsis. The absolute trigger for an emergency surgical airway is acute respiratory compromise combined with a failed endotracheal intubation. When oxygenation cannot be secured through the mouth or nose, a surgical bypass is mandatory. Certain anatomical variables force this bypass immediately: massive maxillofacial trauma, severe bleeding into the oropharynx, or a massive structural deformity physically block oral access, removing intubation as a viable option. In adults, the standard default intervention for these blockages is a surgical cricothyroidotomy. A scalpel is used to incise the cricothyroid membrane, establishing a direct, definitive airway below the obstruction. However, this algorithm hits a hard stop when the patient is under 12 years of age. The pediatric cricoid cartilage framework is highly compliant and structurally underdeveloped. Unlike the rigid adult larynx, the infant and child airway lacks the dense calcification required to support a transverse surgical breach. Watch what happens to the pediatric cartilage framework when breached by a scalpel. The incision instantly buckles the compliant cartilage. Instead of creating an opening, the structural integrity fails, triggering a catastrophic subglottic collapse. The intervention destroys the very airway it is attempting to secure. To bypass this structural limitation, needle cricothyroidotomy is the only viable, anatomically safe alternative for the pediatric airway. A large bore catheter is inserted through the membrane, avoiding the use of a scalpel entirely. Percutaneous jet ventilation is then attached, utilizing high-pressure oxygen bursts to sustain oxygenation without requiring a self-supporting cartilaginous opening. Consider a deteriorating 4-year-old presenting with a severe retropharyngeal abscess and total airway occlusion. The clinician must override the reflex to perform an incisional cricothyroidotomy, recognizing that the scalpel will cause an immediate structural collapse. Age defines the structural threshold of the airway. When the patient is under 12, the physical limits of the cartilage mandate a total departure from standard adult surgical mechanics. This 3D vector cross-section of the eye maps the anterior chamber. It is a finite space governed by strict fluid dynamic pressure tolerances, where aqueous humor is continuously produced and then drained through the trabecular meshwork. In acute angle closure glaucoma, or AACG, the iris bows forward. This physically occludes the trabecular meshwork. Fluid continues to be produced, but the drainage pathway is sealed, resulting in a pure mechanical outflow obstruction. The resulting pressure spike is severe, often exceeding 40 millimeters of mercury. Patients present with sudden, extreme eye pain, a hard red eye, visual halos around lights, and a fixed mid-dilated pupil that is unresponsive to light. Salvaging the optic nerve requires a hyperacute decompression sequence. First, topical beta blockers like timolol or systemic agents like acetazolamide are administered to immediately shut down aqueous humor production. Once production drops, pilocarpine drops are applied. This physically constricts the pupil, pulling the iris tissue away from the angle and mechanically reopening the obstructed trabecular meshwork. Central retinal artery occlusion, or CRAO, operates on an entirely different mechanical failure. Rather than an outflow block, CRAO is a sudden inflow vascular occlusion, typically caused by a microembolus lodging in the central retinal artery. Because the blockage is vascular, there is no pressure buildup in the anterior chamber, and therefore no pain. The patient presents with sudden unilateral blindness. A fundoscopic exam reveals a pale, swollen retina with a characteristic cherry red spot on the macula. The retinal tissue has a strict 90 to 120-minute ischemia window. Once that time elapses, the infarction is irreversible and the vision loss becomes permanent. In this sequence, we see the mechanical action of rhythmic ocular massage. Applying fluctuating high pressure to the globe aims to physically dislodge the embolus, forcing it down into a smaller distal branch to immediately restore blood flow to the retina. Salvaging ocular tissue requires immediate, precise differentiation. The clinician must correctly identify whether the crisis is a mechanical outflow obstruction requiring fluid reduction or an internal vascular occlusion requiring embolic dislodgement. A globe perforation injury occurs when blunt or penetrating trauma structurally breaches the outer layers, compromising the sealed integrity of the ocular chambers. The clinical signs of a loss of structural integrity are absolute: a teardrop-shaped pupil pointing toward the laceration, extrusion of the vitreous humor, a suddenly collapsed anterior chamber, and restricted ocular motility. Ocular chemical burns present a distinctly different timeline of tissue destruction. The immediate threat depends entirely on the chemical properties of the offending agent. Notice how alkali chemicals aggressively attack the eye. They dissolve ocular tissue through liquefactive necrosis. This chemical reaction saponifies cell membranes, allowing the alkali substance to penetrate deep into the corneal stroma and anterior chamber in seconds. Acid burns, conversely, trigger coagulative necrosis. The acid denatures proteins on the surface of the eye, which creates a physical barrier of necrotic tissue that limits the depth of further chemical penetration. Because alkali burns penetrate so rapidly, there is an absolute triage directive: immediately bypass all standard visual acuity checks and slit lamp exams. Documenting vision loss wastes seconds while the cornea is actively liquefying. The definitive immediate intervention is continuous high-volume irrigation, typically using a Morgan lens. The eye must be flushed continuously until the conjunctival pH normalizes to a safe 7.0 to 7.4. There is one strict contraindication. If a globe perforation is suspected alongside the chemical burn, all fluids and tonometry must be banned. Applying pressure or flushing fluid into a ruptured globe forces the intraocular contents out of the eye. A rigid shield must be placed instead. In cases of active chemical tissue degradation, adhering to standard diagnostic momentum, like checking a vision chart before beginning empirical washout, guarantees irreversible blindness. This flowchart maps standard diagnostic protocols in the trauma bay to catalog cognitive traps where algorithmic thinking fails. Trap 1. Delaying chemical washouts to document visual acuity ensures the cornea continues to melt. The protocol must immediately reroute to continuous irrigation. Trap 2. Performing an incisional airway on a child guarantees structural collapse. The algorithm must automatically redirect to a needle cricothyroidotomy. Trap 3. Encountering a fixed, mid-dilated pupil in a trauma setting and assuming it is purely a neurogenic reflex from a head injury. Missing the hard, red eye of acute angle closure glaucoma prevents the administration of pressure-lowering agents, destroying the optic nerve. We synthesize these variables in a final crucible scenario. An adult patient arrives in the trauma bay with massive mid-face fractures following a severe collision. Two compounding variables are identified immediately: a right eye globe blowout and sudden left eye vision loss. First, the airway. Mid-face fractures block oral intubation. Protocol locks onto immediate surgical cricothyroidotomy. Next, the right eye blowout mandates a rigid shield, strictly prohibiting tonometry and irrigation to prevent vitreous extrusion. Finally, sudden left eye vision loss indicates central retinal artery occlusion. triggering immediate ocular massage and IV acetazolamide to attempt embolic dislodgement. Standard algorithms are built for standard presentations. In high-stakes trauma, survival depends on a clinician's ability to abandon diagnostic curiosity in favor of immediate, anatomically dictated physical overrides.